Good morning, everyone. Thanks to the organizer for the invitation to moderate this session on technological updates. I'm Stefania Montemezzi, head of radiological department of University Hospital of Verona. And let's start with the first speaker. The first speaker is Charles Voyton, researcher at Frederick Bost Lab Institution in French, and he will tell us about nodule characterization. Please.
All right, thank you, everybody. In fact, I am Charles Voyton, but we are from Median Technologies working on AI devices for characterization and detection of lung nodules, if I can get this running. But so yesterday we heard a lot about AI and how people want to use AI for lung screening, not just to help it make it more performant or more accurate, but to also help it become more accessible to especially lower income populations, so to help democratize AI. And so for over the last few years, we've been trying to be one of those AI companies, part of the tidal wave we heard about in the last talk about the tidal wave of AI. But where we really started from was looking at what are the current approaches, what are the current availabilities. So if you look around for at least a decade, people have been using computer-aided detections with their own drawbacks, namely that even if you find or delineate the nodule, you still have the task of identifying what is the cancer risk of this nodule. The second being, which are much more recent, CADXs or computer-aided diagnosis, which again have their own drawbacks of first needing to actually find the thing you're interested in characterizing, and then kind of a throughput issue where you can only look typically one by one. So we looked for more of a synergistic approach of adding these two steps together, an end-to-end device, if you will, for the detection and characterization of nodules, where we think we take the strengths of both and combine them into a single detection and characterization stage. But really what we want to look at today is the kind of road and the technological pieces involved to have this, what we call CAD-E-CADX. But of course, that's easy to say, but less easy to actually implement. So we have this long list of pieces in order to actually end up with a final patient level scoring, or with nodule level scoring as well. So we have the input of a CT scan with organ segmentation to help better guide the device's segmentation and characterization. Then for each nodule, solid and part solid are detected. And for each of these nodules, there's a rounds of different AI models that then characterize and provide a malignancy prediction for each of these nodules. With all of these together, they are then kind of pulled together and given a user-readable score and provided as part of the iBiopsy report. So really what I want to look at today is the end performances, but also some of these steps in between, showing that sometimes the sum is greater than its parts. So starting with the sum, I suppose, the results of the end-to-end performances. So this device was trained primarily with NLST patients, but also with the addition of LIDC, because it's a great resource. So if it still is there, we might as well use it. So it's roughly 10,000 patients total, with a test set reserved of 2,000 patients, with 170 cancer patients within that test cohort. And so, as mentioned before, there's quite a number of steps and quite a number of AI models deployed there. And what we have in this ending here with this end-to-end portion is an AUC of 0.97, which we are very happy with these results. But really what I want to do is dig deeper into this, start to look under the hood of the AI, or inside the black box, if you will. How do we get to these kinds of performances for the entire pipeline of our device? So one of the internal bricks, I suppose, which was published and presented in ESMO and also MIC AI, which is an AI focused event is what we call morphomics. It's similar to radiomics, but we actually find some additional kind of curvature features or some other explainable features that help, especially looking at speculation or other shapes of the nodules that help to explain and derive other biomarker features to help us derive our RAI scores. And then, and we've heard many, many times, especially yesterday, that for our CAT-X portion, we wanted to look specifically at the early T stages. So the early small nodules, smaller you find them, the more treatable, more curable the disease is. So this is looking at only nodule characterization, but if you look at this versus the entire cohort with a 95% sensitivity and an AUC of 0.99, there is really, in stage 1 cancers and in small or indeterminate pulmonary nodules, we keep very high discriminatory accuracy for benign cancer. But regardless of how good your model is or your device is, if you can't prove that it has clinical validity or that it's clinically safe, nobody's going to adopt it. You're not going to have an FDA acceptance, and nobody will use it in their clinics. So what we have planned, and really, I think people realize that once you get to the clinical validation, it's the beginning of the end, but in fact, it's the end of the beginning. So we have 2 studies planned in the next few months. One of them being a standalone performance. Some will call it a technical performance assessment with multi-centers across the United States and the EU. About 10 centers looking for 1,000 patients, where we will test, I would say, AI in the vacuum. How good is the AI without intervention from a human, with the primary objectives of AUC and sensitivity above a certain threshold. But maybe the most interesting, most critical from I guess everybody in this room's perspective would be the clinical validation. So the multi-case reader study, where we're going to have 16 total readers read between 360 and 480 cases, depending on the results of the pilot study for sample sizing. And with this, we actually get to see what is the impact of the devices with and without our device, and what is the increase in diagnostic performance, what is the increase in patient management, what is the increase or decrease in patient turnaround time. So these are really the interesting pieces. But that's where we are today, and with hopefully, we all stay tuned. We should have this finalized in the next few months. But with that, I'll thank everybody for their attention and sign off there. Thank you.
Thank you very much. I think if we have time, we can ask questions at the end of the session. And now let's move on the next speaker, Ricardo Avila. His presentation is about CT calibration. Please, thank you.
All right. So this is going to be fun. Whoops, you've got a preview. So I think we've all been watching these wonderful images come through of the new Webb telescope. And it's important to look in the past and just say, basically in about 18 years, we've gone from the images on the left of the same, let's say, part of the sky to the images on the right. And this is causing breakthroughs and, just tremendous excitement throughout the world. We're understanding the universe much better. But if you go in the other direction, and if we focus on lung nodules, the reality is, I was thinking about this last year. These are just 2 publications I pulled from, just the web. The difference between the images we were getting around 2003, 2004, and this is 2007, and 2023 today are not that much different. We're not really seeing a big improvement in resolution, although I have to say the photon counting scanners can do a lot better. But in the field right now, these scanners are pretty much giving us about the same in-plane resolution that they have for a long time. So let's see if I can move this forward. Can you advance the slide? Oh, thank you. So I got to asking the question with David Yankelevitz and many other people around the world, Mario and Stephen Lamb and others. What would happen if we created a really small object and we put it in the scanner, just like a lung nodule is detected now? And this is a 6 millimeter. It's got actually the core of that ellipsoid is 41 millimeters cubed, so well below what Matthias was saying we should be measuring. And printing, actually creating a 3D print of that is extremely difficult, but we managed to create it, and we go and scan it about the field of view that you would for a normal patient. And if we zoom up, if we do a reformat and we zoom up on that, that's what we get. So it's quite a bit lower quality than you would expect, but that's the reality right now everywhere. And why? Because we take a 512 by 512 pixel matrix and we stretch it across the entire field of view. And yes, there are scanners that support 1024 by 1024 and other things, but it's almost never used. Radiologists have determined they really want to operate about 1 millimeter, 1.25 millimeter slice thickness, and a 512 by 512 matrix. And I think we have to accept that. But what if we had AI while the patient's on the table still, review the scan, find any serious abnormalities, and then suggest an additional scan before the patient gets off the table? What could we do if we did that? Now, the technologist would have to decide whether to go forward with the additional acquisition, but we could do some really dramatic things if we allowed that. So this is an example of taking that same object, doing a targeted acquisition where we cut the slice thickness in half. We double the dose. We don't have to double it, actually. We'll get into the math of that later. And we create 4 times as many samples in X, Y, and Z. So that's 64 times more data samples. Now, that image, if you compare the two, they're quite a bit different. Now, I put some linear measurements. I measured the length of those cones, if you will. They were 1 millimeter in diameter, stretching down to 0.3 millimeters and over an 8 millimeter length. So the possibility of getting very high resolution acquisitions, very high sampling rate acquisitions is quite striking, actually. And I'll do this again. Of course, all of this is to do this right, as I'm suggesting. You would need to look at this fundamental relationship between resolution and noise, as well as you need to consider the signal processing fundamentals as well, including basically the sampling rate. And to do that, you would, of course, want to use calibration information about your scanner and your protocol to not over or under, let's say, basically sample or provide radiation dose to the patient. So when we go and we do this and we actually look at the bias and precision of just diameter, I mean, simple linear measurements, we're seeing a 650% improvement in the precision, the coefficient of variation, and a 625% improvement in the bias of the length of those objects there. And if we go further and we look at the volumetric appearance of these objects, on the left you can see it's kind of like a piñata I would have made when I was 10 years old. And on the right you can actually see a good visualization of the object as it was created. It's not perfect, but it's much better. If we create another object, which is this little bottle I've created here, it's got air voids in it of different sizes. You can make it with the 3D printer. And here, if you measure the cylinders and compare them between these two scans, we're talking about a 1,000% improvement, 10 times improvement in our ability to precisely measure the volume of those cylinders, and an 864% improvement in the bias. That's because we're getting bleeding of the segmentation from one cylinder to another, and that's causing havoc. But that's going to happen in real life. And we also did this on another scanner, a Siemens scanner, and we saw even more dramatic numbers. Obviously, it gets a little ridiculous when everything starts to bleed into one another. But the results are really quite hot, quite good. And if we look at the spheres, those are spheres on the outside of that cylinder. And those are just completely not measurable. Those are 1.5 millimeter diameter spheres. They're completely not measurable in the original scan, but not in the but are measurable in the targeted scan. And then I'll just move on quickly. This is true in medical images as well. And so this is we managed to get hold of a scan with targeting, and you can see airways that are not visible in the original, but are visible in the target. And then one more, there are vascular and airways that are not visible in the original, but are visible in the new one. So this has many implications. Basically, the big one is that this is available potentially one day for all CT scanners. It doesn't, and there's lots of possibility here to greatly improve our ability to measure small lung nodules. So thank you.
Thank you very much for your presentation. The next speaker is John Ioculano, Senior Director, Solution Architect at Varian Medical System. No, it doesn't.
Hi, good morning. I'm online. Can everyone hear me okay?
Hi. The title of his presentation is Enhancing Communication.
All right, thank you. Well, good morning, and thanks very much for the invitation from Dr. Jankelevich and Dr. Henschke. Appreciate the time. I'm switching gears a little bit this morning to talk about enhancing communication for patient engagement. My name is John Ioculano. I work at Varian Medical Systems. And part of the reason why we're looking at patient engagement as an important part of lung cancer screening is clearly it's key in spite of all the talks and in spite of all the background around AI and machine learning and all the various indications of that. It boils down to getting the patient to the clinic and understanding the context by which patients are engaged as part of their clinical care for lung cancer screening. So a little bit of background, and again, this has been discussed. You know, there's some clear messages around making sure that we reduce barriers for lung cancer screening. We have to make sure that there's awareness for patients. We understand some of those perceptions of why patients don't come to lung cancer screening, whether or not it's burdens in terms of psychosocial awareness, the concerns around cancer diagnosis and stigma. But also we understand that it's really important that this is an end-to-end process, and really connecting the patient to the provider helps remove those barriers and provides better indication for tracking. You know, again, with those challenges with lung cancer screening, we feel digital engagement and those, you know, making sure that the patients are, connected to their provider is super important. You know, seeing things like lack of awareness, unfamiliarity with guidelines, stigma, perception, knowing how to conduct shared decision-making. These are really important facets of care. And connecting the patients to the provider with a digital tool, in our mind, is key to that success. We want to make sure that we provide the most prevalent access and reduce the most barriers. And moving into the digital world is clearly an indication that we see our patients are really hoping we can support. This isn't new. There's lots of data that suggests that implementation of digital awareness and strategies to help engage patients can help lung cancer screening programs. The conclusions we really draw are situated here in that, these campaigns and, providing digital engagement and patient education really allows for patients to connect with their providers. So we see that this is going to be really important as part of two-way communication. There's clearly going to be access to the patient's hands, whether it's with a mobile device. We know that mobile devices are in everyone's hands, whether you're patients or providers, and having clear communication back to the provider with a digital platform, engaging in those touch points really helps support the workflow, integrate with EMRs, and really starts to transcend the type of indications and the type of communication that we require for patients. So that enablement is required and helps in a number of facets. When it comes to self-enrollment, we see that as a key facet of coordination. Long-term care and using validated instruments like patient-reported outcomes can really help provide ready feedback and regular feedback back to providers, using custom questionnaires, creating really robust referral system support, marketing campaigns in terms of community outreach. Again, I talked about serving up patient education instead of digital tools and helping for shared decision-making, physician engagement, and lastly, that quality factor and financial metrics. Increasing capacity and seeing that cost-effectiveness view becomes really important as part of value-based care. And really, when we think about it, it starts at screening and diagnosis, but goes through the whole cancer journey from screening to survivorship. So we see this as a digital engagement opportunity to connect care right from the very early onset, but during surveillance and survivorship and through treatment, we do understand that patients want to connect to their providers, want to stay really closely connected to them, and helps reduce that fall off that we all too often see patients in the community. A really large part of this is patient education. We know that, getting information to patients on the ready regularly and very clearly can help engage patients and keep them connected to their providers. Obviously, with patients who have digital tools at their hands, they'll more readily access that information, and we see that opportunity growing. It's really clear that this is a worldwide burden, and we understand even in disadvantaged populations that many patients have mobile devices already. So having this information at their fingertips will enable communication very quickly. We really also see this as an opportunity for shared decision-making. This is very clear information and correspondence between care teams and their patients. Having that opportunity to have a longitudinal view in terms of responses, facilitate informed discussion between the patient and provider, really enables a really strong connection between the patient and the provider. When we start talking about the ongoing touch points, it really becomes clear to us that digital engagement becomes an ability to create configurable templates to allow for surveillance communication and a plan to happen between the patient and the provider. So whether or not that's at the beginning, during the first few weeks and ongoing, whether it's monthly or quarterly, continuing to repeatedly touch the patient and have them access information and correspond back to their provider are clear strategies to enhance engagement. And this isn't new. We're learning strategies associated with other screening events from breast, cervical, and colorectal screening guidelines that we've learned along the way. We understand that the recommendations that are out there and the guidelines are out there allow for patient-oriented interventions on a regular basis. So, we're just taking what we've already known from historical screening programs and applying them to lung cancer screening. So a typical walkthrough in terms of enhancing communication for lung cancer patients would be, first identifying the patients at risk, understanding who that patient is. As the patient understands the value of digital communication, they could be introduced to annual screening, sharing information, via baseline questionnaire, reporting symptoms and getting educational material served up, and even scheduling reminders for appointments. The patients in this case, whether it's self-enrollment or conditions to enroll, are invited to engage in a digital platform. They end up being part of a lung cancer screening template where appointment reminders are set forward. And at the end of the day, as we want to indicate, early interventions, allowing indications, moving forward in terms of high-risk events. And then lastly, the patient can receive annual screening reminders with clear indications and instructions.
Please, Dr. Ioculano, can you finish, please? Because the time is over.
Okay, I'll finish with this slide here. I'll just end by saying that, the most important aspect of this is accelerating the lung cancer treatment pathway. We can obviously see that early indication can also allow us to move forward from things like diagnosis all the way to stereotactic body radiation therapy. So clearly something that we can appreciate long term. Thanks very much for your time.
Thank you, Dr. Ioculano, for your presentation. And so we move on the next speaker, Francesco Petrella, Professor of Thoracic Surgery at the University of Milan. His presentation is about new CT to lung mixed reality platforms. Please.
Thank you, Mr. President. Thank you for the kind invitation. And the topic of my presentation will be about the role of holograms in thoracic surgery. Before starting the presentation, I would rather focus on the definition of holograms. Without going into too detailed definition, I have to say that a hologram is an image that you can bend, you can rotate, you can split, you can turn around, and you can have a 360-degree evaluation of the whole target. And so you can apply this kind of technology even to vascular and pulmonary anatomy, and you can have very interesting results in terms of preoperative assessment. So my group and I were wondering how to apply this kind of technology to clinical daily life of a thoracic surgeon. And we decided to compare the data coming from standard preoperative CT scan with data coming from preoperative CT scan and holograms. So we enrolled 50 patients in a prospective double-arm trial. And we decided to enroll patient with a planned anatomical resection for lung cancer. And we exclude contraindication to general anesthesia, patients unable to provide informed consent. The target of our study was to compare the efficacy of both diagnostics in terms of preoperative vascular anatomy. So pulmonary artery branches, as well as pulmonary vein, although vein anomalies are less frequent. This is a short movie regarding how hologram works. This is a case of left upper lobe cancer. You see here the yellow-green lesion of the left upper lobe. We have previously removed the pulmonary venous system, and we have left the bronchial tree in light blue and the arterial branches in red. So you can see the mediastinal branches to the left upper lobe, and then you have the hilar branches to the left upper lobe, and you can clearly see the B6 artery. I think that this can really support your preoperative planning, in particular when you are considering to perform a minimally invasive approach, video-assisted or robotics, where you lose your tactile feedback. And so you can have a 360 degree from the back, from the upper part, from the lower part, so you can really know before entering the chest how the vessel have reports relations with the tumor, with the other branches, with the lymph nodes, with the bronchial tree. And I think that in the end, you can have a safer approach to the resection. With regard to our results, we are still working on it, but I can just anticipate some data. And I can have to tell you that the highest variability is in the left upper lobe artery. We had 3 from 6 branches, while in the lower lobe, considering the B6 and the basal pyramid as just one trunk, we have always only one trunk. So I would rather say that the biggest advantage of this technology will be in the left upper lobe arterial system, thus foreseeing how many arteries you have to resect and what is their takeoff and tail route. Before concluding, I want to thank all the colleagues and groups that I had the pleasure to work with for this trial. And I want to thank you all for your attention. Thank you.
Thank you, Dr. Petrella. Thank you to be on time. And now the next speaker is Mario Silva, radiologist from University Hospital of Parma, who will tell us about minimizing radiation exposure.
Thank you, Chairman, for the introduction, and thanks to Maurice Infante, David Yankelevich, and Claude Enschke for having me here today. It's a great pleasure talking about low-dose CT. It's a technical speech over here. Try to fly over different options to do low-dose CT while maintaining quality, and I'll be explaining why we see both computer and real eyes over here. So when we do lung cancer screening, we need image quality, and while we need dose reduction. And to do that, you would have seen here that we have volumetric acquisition, we've been talking about in the panel before, and thin slice. We see nodule and several other things that will be discussed in the next session over here. And we read it with visual reading and quantitative analysis. Why do we need to reduce the dose? Well, the reason for reducing the dose over here is explained by the increased risk of causing a cancer. This was quantified in a paper from the group of Rampinelli et al. Already 6 years ago. They could calculate a risk over 10 years of up to 8 lung cancer induced by low-dose CT. The technology of that time could guarantee a 9 to 13 millisievert exposure, depending on the gender. So from that time to today, things are changing, are evolving quite rapidly. So to give you a glance of what is going to happen with scanners, what actually already happened with the scanners, we're going to act over the X-ray source, so the tube that gives the dose, the detector. If you have a camera, you want to have a 42 pixel detector for that. And then you can do some post-processing for your histogram images, make it nicer for several reasons. So I'm sorry the animation is not working over here, but we'll manage anyway. So we have references for dose, and this comes from the ACR, the American College of Radiology. The dose should be below 1 millisievert, but beware that it's not valuable for everybody. And it really depends on the weight of the patient. So if you want to go deeper in the sea, we need more light. If the patient is larger, we need more X-ray. It's basically the concept over here to reduce the noise and increase the signal. How can we do that? Well, the ACR guidelines provide a full list of every CT scan that you have commercially available today, and you can do it by yourself with a reference. Or if you want to work around with your own CT and decide which CT you want to buy for your lung cancer screening, you might be aware of a few things that help you to reduce the dose while maintaining the quality. First one today is the beam filtering. Just like polarized lenses, when you look at the landscape, you have signal that goes from the tube across the patient and to the detector that does not contribute to the actual signal, but is just noise and radiation. So what are we going to do? Just like with polarized lenses, we pre-filter radiation, either with thin filter, this is from Siemens, or a silver filter, this is from Canon, and we reduce the dose that would interact with the body, given increased risk of cancer, but would not contribute to the image. But that's a very simple concept. There's also a scheme over here that you can see how the dose can be dropped down to the dose from the red line to the green line and have the same quality of the image over here, because you're dropping this part of the curve by the filtering. So first information over here is that filtering the beam, the X-ray beam by a button, the low energy photon is already a dramatic reduction in dose, while not having a detrimental effect on the noise and on the signal. Well, we go from the source of photon through the patient, and then we have detectors. Today, 99% of the CTs all over the world are working with this technology that performs like this. At the increasing radiation dose, there is an increasing sensitivity of the detector. But what about a detector that has stable responsivity to the signal across the X-ray energy, so across the dose? This is now the technology called photon counting. It's really expensive technology over here. If you want to buy this CT, you have to manage to get to $2.5 to $3 million to buy this machine. And so probably a bit expensive to think about this thing today for lung cancer screening, but the technology is there. We just need the scalability to bring it all over. What is the message over here? If you have this kind of detectors, you will have less image noise, because under the threshold of a certain energy, the signal is not perceived. And that threshold actually just contributes to noise, this blue boundary. So this detector working, for instance, with the beam filtering is doing a great job for reducing the noise. And what does this mean? Well, this is great to reduce the artifacts and make CT numbers more stable. So we've seen the edge of the nodule to do the volumetry, and that's a big thing, a very important one. But if you think also about intra-nodule characterization, we've already heard about radiomics today, probably not ready for the prime time in clinical practice, but this is one further tool to go further and help with that. And of course, you have spectral measurement all over with this. Third thing you can do, you have your image, you want to put it on Instagram or in your software, and you want to have a better image. So after the reconstruction, you will be using this filtering to reduce the noise and have image quality, higher image quality. So let me wrap up the presentation with a last consideration over here. Probably the presentation was not completely digested by the computer. Sorry for that. What are we doing in our lung cancer screening protocol? We're reconstructing one reconstruction for the CAD software, which is cleared by Kiba Phantom, but this is not so good for human eyes. So we're reconstructing also for visual reading over here. And what is the cost in terms of dose for this thing? Well, sorry for that. It's really comparable to a mammography. So this is the layout we're reading over our lung cancer screening trials, visual, CAD, and mediastinum and soft tissue all over, and also cardiac calcification with this. And the dose is comparable to mammography with high quality images. And thank you for your attention.
Thank you very much. Thank you very much for your interesting presentation. And now, finally, the last speaker. So Saurad Gombar, pathologist from Stanford University, with the theme of real-world outcomes in early stage non-small cell lung cancer.
Hi, thank you so much for inviting me, and excited to hear all the talks that have come before. I'm going to actually move away a little bit from radiology and talk a little bit more about all the data that can be available within a large longitudinal health record data set and how it can be utilized for patients. So to start with, the cornerstone that we're taught in medical schools, this concept of evidence-based medicine, which officially is defined as the conscientious, explicit, and judicious use of current best evidence in making the care decisions of an individual patient. However, as clinicians, often when we would want that mountain of evidence that says, what should I do for Mrs. Smith? We're often confronted with a molehill. And the reason we have such little evidence sometimes is that the largest RCTs in prospective trials about patients, they tend to remove patients with 2 or more common comorbid conditions. So on the graph on the left here, you can see that about 80% of trials will remove patients with 2 or more common comorbid conditions. However, that has a lot of trickle-on effects into the healthcare system. So first thing is that about 70% of all of our healthcare spending is in that group of patients that have the multiple comorbidities. The other issue is that the cornerstone of our clinical decision-making, our clinical guidelines, only about 19% of them are based on what we would consider level 1A evidence. As a result, for decades, physicians have been thinking, I take care of these patients every single day. Why can't I use that information to guide my therapy choice? Our most recent history of this actually goes back to 2011. Dr. Jennifer Brankovich at Stanford taking care of a pediatric lupus patient. And that patient had antiphospholipid antibodies to autoimmune condition, pancreatitis, inflammation of the pancreas, both of which got them removed from studies about pediatric lupus. And she just wanted to know, do I anticoagulate this person, yes or no? She also happens to be a prominent researcher, had access to every EHR record of every patient with lupus. And so what she was able to do was quickly mine those records to guide the therapy choice for that individual. That led to the NEJM paper all the way off on the left here in 2011, and then several groups at Stanford thinking, okay, how do we take what Dr. Brankovich did and make that routine for every single individual that walks in the door? So in 2014 to 17, a lab run by Dr. Nigam Shah built a lot of technology to rapidly mine EHR data. And then from 2017 to 2019, we actually ran a pilot at Stanford that provided a service, just like you would consult rheumatology or you could consult the pediatrics, you could now consult informatics and say, tell me what happened to every single patient that's ever looked like this before, quickly generate publication grade evidence, and then utilize that at the point of care. The way that works, and what we dub that as the informatics consult service, is basically a physician in their EHR or in a portal would write down a question the same way they write it, normally would consult a colleague. A physician staff on a consulting team would receive that, make sure that the question can be defined and answered in longitudinal EHR data, and then use a bunch of custom technology to generate a report to answer that question. And an example of that would actually be something like this. So this is a fantastic clinical trial that was published earlier this year in NEJM, looking at lobar and sublobar resection for peripheral stage 1A non-small cell lung cancer. So this is a fantastic paper. Obviously, it summarizes years of work, millions of dollars. However, as many of the people on this call probably know, this has been a hot topic for pulmonologists for a long time, and there's been many observational studies trying to answer this as well. So what would a question like this look like in the informatics consult world? And so to that end, let me switch over to an example. I'll zoom out for a second. Just I know no one can read this, but just want you to see that it looks and feels very much like every observational study you've ever seen in the past. So for example, in this case, the question we actually received was, in patients with non-metastatic lung cancer, how do outcomes differ between patients who receive a lobectomy versus a limited resection? The first thing that would happen is that this goes to a clinical team, so a group of MDs that have been trained in informatics that reformulate the question into a PCOT format. And again, think back to medical school, sort of drilled into our minds about how do you make an actionable question. So what is a population, intervention, control, outcome, and time frame? We're very clear in our methodology. There is no black box here. There is no AI, no deep learning, just very clearly definition of what the question is. And similarly, very clear definitions of how any of this is actually defined in the longitudinal data. What does it mean to have one? What does it mean to have a lobectomy or a local resection? How much history must you have prior to this? This is all put into a custom technology stack that uses sort of just standard data science, data analytic methodologies, and it produces a report that looks like every paper you've ever seen before. It's a quote unquote demographics figure that breaks down the male-female ratio, the age distribution and racial profiles of these patients. Similarly, a quote unquote table 1A has all the same information I just mentioned, but some things that are really relevant to these large EHR studies, like what year were these patients treated, how much history did they have, their comorbidity. So we automatically take something called a Charlson Comorbidity Index, that would be very common to the physicians that are in the room, and break that down between the cohorts. But where the real magic happens is the outcome. So in this case, we looked at death, length of stay, metastasis, and we don't give just a percentage of patients that developed it. It's not just a data snapshot. Where it really exceeds is being a statistical analysis. So all of the analyses are done in triplicate. So here's one example. The outcome here is complication, and we're looking at everyone that had a resection versus a lobectomy. Then we're doing basic matching, comparing for age and sex. And then finally, something called high dimensionality propensity score matching, fancy technique to make sure we're comparing apples to apples. You don't want one arm of diabetic smokers, one arm of healthy 30-year-olds that just happen to have some incidental cancer. And that happens for every single outcome. This was a binary outcome. Did it happen, yes or no? But we also can do survival analyses like time to metastasis or time to death. And our findings, in this case, were very similar to the findings of both previously published observational studies and the RCTs. And in this case, what happens is our medical team writes a summary. That summary is put right behind the question. And as a requesting provider at the point of care, all it is knowledge work. I have this question. Here is my answer. I'm going to move on with it. If they want to double click on anything, they can do that. And this can be requested by researchers, physicians, or protocol developers within an institution. And that is how this works. And that's an example of some of the questions we've received around lung cancer therapy to date. You can see a lot of it's based on multiple comorbid conditions. Do patients with interstitial lung disease who undergo radiation therapy have an increased risk of reoccurrence on immunosuppressive drugs? What is the rate of myelosuppression following third generation EGFR TKIs in patients with advanced non-small cell lung cancer? So a lot of questions that are broadly interesting to physicians that have not yet been published on. We can mine the past patient records to answer it. And with that, I know I'm running a little bit low on time. Just want to emphasize that the data is coming across a large collaboration.
Dr. Gombar, please, you have to conclude.
Okay.
Thank you.
Okay, and thank you for your time. And with that, I will leave it. So thank you so much.
Thank you, Dr. Gombar. So let's conclude this very interesting session. We don't have time for questions. Thanks and congratulations to all the speakers and to organizers, and enjoy your coffee break.